Hello everyone. This is Dr. Pritpal, an MBBS MD from CMC Ludhiana. And from the past two videos that I have been talking about, I'll continue my discussion further on outcome assessments and how we can improve the outcome assessment, because outcome measures are one of the most important parameters that tend to influence our study. If we have done our study well and we have represented our study well, and outcome measures would help us represent our study to the appropriate level and will help us in proper publication of this particular uh, study results. So I'll start with the brief recap of what I have already been telling, and we'll try to go ahead with all the processes. Now, when I was talking about outcome measurements, uh, the purpose of this outcome measure is to improve the patient safety, and one of the parameters is, if you want to go for, you want to improve the safety of the patient, and the other is so. For outcome measures, the first thing that we keep in mind is the patient safety, because it is always said that the risk benefit ratio should always be taken into consideration, and at the same time we need to evaluate the effectiveness of a solution such that in real life settings we can count on it in terms of impact, acceptability and affordability. So what we are going to do is, we have been talking about this, we'll be talking about several methods for evaluation which can be done and which can help us predict better patient safety. So before I go into that patient safety module, I would just uh, give you a brief recap on the hourglass approach of research study, where we have the introduction as a broad base and our methodology and result narrows down, and then discussion we again broaden up. And to formulate a research question, we must follow the PCOT, that is the population, the intervention, the comparator, the outcome, and we might also include the time intervention in that. So when we talk about the definition of an outcome, which we discussed in the previous sessions, was this is a measurable which at the level of an individual, family or community, the behavior or perception that is measured along a continuum and is responsive to clinical intervention. And what does an outcome measure? This is a set of items that are used to create scores that are intended to quantify a patient's performance on health status based on standardized evaluation protocols or closed-ended questions. Now, why measure patients' characteristic using standardized outcome instrument? We want it to be documented. We want it to be used for clinical information, for the development of clinical knowledge and professional education, as well as we want resource allocation and accountability. So we were talking about the various components, and it was a continuum process which we started with. So first we measure the harm, we understand the causes, we try to identify the solutions, we evaluate the impact, and then we translate this into safer care. Again, we measure the harm. So this continuous cycle keeps on going ahead for outcome measures. And the outcome research, we talked about the 6 Ds, which included the death, the disease, the disability, discomfort, dissatisfaction, and the cost, which is interpreted in the terms of dollars. Now, Agency for Healthcare Research and Quality, it tells that outcome research is all about what works, what does not work, what works at what time interval in an illness, and what is the cost of that. That is what we were talking about in the previous slide. And because outcome research has no uniform definition. Outcome research is basically a scientific study of the results of diverse therapies that are used for particular diseases, condition, or illnesses, and this is directly linked to the evidence-based medicine. So the various components of clinical measure that we can talk about is the mortality, the complications, the pathology, the physiological or lab abnormalities, any deformity, and the sign and symptoms that are associated with a particular disease condition. Now, we were talking about the categories of patient outcome, which could be of four subtypes. It could be clinician reported, it could be physiological, it could be caregivers reported, and patient reported. Each one have its own clinical significance. The clinician reported is how the clinicians interprets it. The physiological is how your normal data behaves, such as maybe the glycosylated hemoglobin or the tumor size. The patient's reported is given higher priority, and we also have caregivers reported, which is assuming a lot of significance because directly or indirectly a caregiver is always involved with the patient, or the social milieu in which the patient lives, that is always involved, and that could lead to various uh, that could be one of the components that could be assessed as an outcome measure. The amount of effect it has on caregivers, maybe in the terms of dependency or maybe in the terms of functional status. Now, before we do that, we need to outline the study, and this comes up with the following points: that what is the presentation of the patient at baseline, with what condition, what is the treatment that is uh, the patient is expected to receive, and what is the response of this particular patient. We also talked about the biases, and the confounder bias is a compared component which are not sufficiently similar. There are two types of bias, which could be selection bias or treatment bias, which I had discussed in my previous session, giving an example of what a selection bias could be and what a treatment bias could be. Or there could be confounders. There could be that these are variables that, although they are thought to cause an outcome in actually, and they are not responsible because of unseen effects of another variable. These confounders could be, giving a typical example, could be uh, lung cancer with smoking, and maybe some other parameter associated with lung cancer. Then we talked about uh, how do you know if the care is safer. This is basically one of the outcomes that we can look into the frequency of, we can look into the prevalence of outcome care, we can change in practice in response to learning, and we can also have an improvement in the safety culture. So we need to first have a baseline assessment where we need to define the disease, we need to set in the proper inclusion and exclusion criteria or the proper selection criteria for the patient. We also need to have the disease severity, and this disease severity could vary with the disease, such as if we are talking about the cancer, we normally go for TNM classification, or maybe if we are talking about sinusitis, one of the parameters that is used is McKay-Lund, and the other one is Harvard, which could go for reproducible result, or we could also look for various comorbidities. One of the parameters for the comorbidity is the adult comorbidity evaluation 27. This is a validated instrument for evaluating comorbidity in cancer patients. We also talked about the donor median cycle, where there is a structure, there's a process, and there's an outcome, and how is it related. We have the pathophysiology, we have the symptoms, and these symptoms then manifest as a property of a physical or mental health, and how it affects the quality of life. We were talking about the various domains of quality, which included the safety, the effectiveness, the patient-centered, the efficiency, timelines, and equitables. And we had the various different perspectives for outcome. There could be a clinical perspective, there could be a patient perspective, there could be a societal perspective. Clinical perspective is what the clinician feels and what the physiological parameters go ahead with. Patient's perspective is the patient's feeling, his subjective health status, his quality of life, and his satisfaction. Whereas societal perspective is, maybe when we talk about the caregivers, one of that could be factors in societal perspective, where we talk about the utilization and cost of that particular intervention. And if we want to go for safety measures, there is invariably, we do tend to have uh, safety studies also, where we tend to look for the harm as an outcome. What harm could this particular process cause? Maybe we could go for an example of thalidomide with phocomelia. We could look for appropriate care related to that harm. We could go for what learning did we have, and what was the safety culture that we started following. Maybe thalidomide, we have a black box warning with thalidomide. So that is what we need to highlight when we are talking about various outcome measures. Now let's talk about certain examples of an outcome measures. So when you want to measure appropriate care process, you could go for clean care is safer care. What is the learning? You could talk about audits of action taken. You could measure the safety culture for a prospective study, 6-month log cohort study for cost analysis, or you could go for case control study for cost identification as done by Khan. So evaluation could be a direct observation where we go for proportion of appropriate hand hygiene. If we talk about hand hygiene, appropriate hand hygiene per total number of hand hygiene opportunities. Indirect measurements could be the amount of alcohol that has been used, and outcome would be amount of the incidence of healthcare acquired infection. So it all these goes, the process and outcome go hand in hand. Then what exactly did we do? What was the various evidence-based practices that we followed? Did we measure the presence of the policy or the programs? For the staff knowledge, or the staff aware about the policy and the programs, or the appropriate use of policy or programs? It could be all these things could be taken. Now, if we talk about the safe culture, we need to have an annual assessment of culture of safety. We need to evaluate staff's attitude regarding safety and teamwork, and we could also go for safety attitude questionnaire when we are talking about one particular phenomena, that is appropriate hand hygiene per total number of hand hygiene opportunities. So this is what we are talking about, and on that basis we are talking about. We could go for a structured answer question teamwork and a safety climate survey where we look for a 5-point scale where we could have a scale from strongly disagree to strongly agree. It could be based upon whether it is difficult to speak. If I perceive a problem with patient care, physician and nurse together well coordinated team, medical errors are handled appropriately out here. So these are some of the examples of how we can go for hand hygiene. Now for the cost outcome, we could go for identification of the cost. We could go for cost effectiveness, which could be quality adjusted life years or daily adjusted life years, or it could be related to cost benefits. For the assessment of treatment, we always need a control group and a comparator. Now, what we were talking about in the beginning was that what is efficacy and what is effectiveness. So when we talk about the efficacy study, efficacy is, let's pose a question for efficacy. Does the intervention work in a tertiary care setting with carefully selected patients under tightly controlled conditions? So what is happening out here? Whenever we are talking about efficacy studies, we are going for a tightly controlled condition where everything is being monitored. Whereas in case of effectiveness study, the question that could be posed out here is, does the intervention work in clinical practice setting with unselected patients, typical care providers, and usual procedures? So normally what we tend to do is we go for an effectiveness study. Efficacy studies are done only when the environment is tightly controlled. If we want to assess the outcome for an efficacy, it could be health intervention in a controlled environment, which tends to achieve better outcome than does placebo, whereas effectiveness, it retains its value under usual clinical circumstances. So most of the time, what we tend to do is we tend to go for effectiveness studies. Now, these are certain study designs and the level of evidences. So we have a randomized control trial. Now, this is one design that tends to prove causation. It is unbiased and to distribution of confounding. Whereas when we talk about the disadvantages of an randomized control trial, it is expensive and complex, and it typically targets efficacy. Efficacy, I told you, is under controlled environment. What is the level of evidence? If the RCT is a high quality, the level of evidence is 1, and if the RCT is of low quality, the level of evidence is 2. Then we talk about cohort studies. These are much cheaper than the randomized control trial. They have a clear temporal directionality from treatment to outcome. But the problem out here with the cohort study is that it is very difficult to find suitable controls, and there will always be a confounding factors. So if there is a control group, the level of evidence is 2. If there is no control group, the level of evidence is 4. Then we go for case control studies, which are cheaper than cohort studies, efficient study of rare disease or delayed outcomes, but they rely on retrospective data. Directionality between exposure and outcome is unclear. The level of evidence is 3. Case series, which you generally tend to uh, go ahead with the publication. They are cheap and simple. There is no control group, no causal link, and the level of evidence is 4, whereas expert opinion has the least level of evidence. So going by this, the highest level of evidence for any study design would be the best study design with the highest level of evidence would be a high quality randomized controlled trial. So looking into this, these are the recommendations. A high level of level of evidence for evidence-based medicine is randomized controlled trial, which has a level of evidence of 1. And then we could go for maybe a low level RCT or cohort study, which has a level of evidence of 2 to 3. A case control study having a level of evidence of 4, whereas a case series has a level of evidence of 5. Now, there are certain habits of a highly effective data user, and these habits we need to look into. We should check quality before quantity. We should describe before analyzing, accept the uncertainty of all the data, measure error with right statistical test, put clinical importance before statistical significance, seek the sample source, view science as a cumulative process. So this is what I have been discussing about today. Now, my focus was on efficacy data, efficacy studies and effectiveness studies. Efficacy studies are done in a closed control environment, whereas effectiveness studies are done in a normal clinical setting. And then we talked about the various level of evidences where randomized control trial has the highest level of evidence, and the case series has the least level of evidence. So with this, I'll end the session out here, and I would try to have the last session of outcome measures in a few days from now. I hope I have cleared a little bit of air on outcome measures with this particular presentation. And if there's any queries that you tend or you feel or you have, you could inbox it to me and I'll definitely get back to you. Thank you so much for your patient hearing and have a great day ahead. Thank you very much.